failure and chronic kidney disease, and to discuss how EMPA can address this interconnected condition. The key message is we have to change our thoughts and how we think about diabetes. We have to think beyond HbA1c. While glycemic control remains important, cardiovascular disease and heart failure and chronic kidney disease remain the leading cause of hospitalization and mortality. Therefore, successful diabetes management require that we have protecting multiple organ and think about the cardiac and renal outcome. The global burden of diabetes and chronic disease and heart failure continue to increase. And although hyperglycemia initiates many complications, cardiovascular disease and kidney disease remain the major cause of morbidity and mortality. This is why therapy with proven cardiovascular and renal benefit have become increasingly important. More than 530 million people lives with type 2 diabetes and over 850 million with chronic kidney disease, and more than 60 million people with heart failure. This emphasizes the importance of proactive screening and prevention, and rather than waiting for complication to happen from the disease to appear so we can interfere. These diseases rarely occur independently, and that was mentioned by our colleagues previously in many slides. Diabetes, chronic kidney disease, cardiovascular disease frequently coexist and accelerate each other progression. Every patient with diabetes deserves that you look at his cardiorenal assessment. 60% of chronic kidney disease patients have already cardiovascular disease, and almost 1/3 of people with type 2 diabetes already have chronic kidney disease. The disease progression, like the question is or the key from this slide is, when is the best opportunity to intervene, before or after complication is happening? And the cardiorenal metabolic syndrome is progressive. Once one component develop, the risk of developing another one is increasing substantially, and early intervention provide the greatest opportunity to have a good outcome. Now, is EMPA is a glucose simply a glucose lowering medication? And to answer these questions, initially they developed for glycemic control, and EMPA glucagon has demonstrated cardiovascular and renal benefit, extending well beyond the reduction of only HbA1c. This has fundamentally changed the way we look at diabetes management and the way we look about the use of CGL2 inhibitor and when to use them. From the EMPA-REG outcome demonstrated cardiovascular and renal benefit in diabetes, EMPA extend benefit into heart failure regardless of diabetes. And across all the way, it has some benefit in all aspects. It has a triple protection, and EMPA has constantly demonstrated a reduction in the cardiovascular death, heart failure, hospitalization, and kidney disease progression, while also improving glucose, body weight, and blood pressure. And this is with the percentage that has effect on them. I'm not going to spend all the time on a percentage, but it's all over the outcome of the studies, which include, or the key messages from the last two slides. Therapy can address multiple outcomes. Now I will be transition to a case that we face and look at on daily basis in our practice that we might see tomorrow. As we review this case, think beyond glucose level and consider overall cardiovascular and renal risk. Treat patients, and we don't treat only HbA1c. We are going to consider this patient a high-risk patient or a low-risk patient. Despite relatively modest hyperglycemia, Fatima has obesity and hypertension, dyslipidemia, and she's over 50 years. Her future cardiovascular and renal risk is significantly increased. And this is some of the risk that can increase the risk of having type 2 diabetes. And the risk assessment for patients should extend the glycemic control. Uh, The risk assessment should begin when we really diagnose type 2 diabetes. And I think sometimes we miss that part. Many patients already have established vascular disease or early kidney disease when diabetes first is identified. So the message that we are trying to convey is try to assess the risk from day one when you diagnose diabetes, because early intervention can lead to a good outcome. So the patient really focus on HbA1c. Uh, from experience, they don't feel that telling them reduction of A1C is important. They don't take it, seriously. I see patients over the years in clinics having HbA1c not to target, and when I start telling them, they worry about discussing the outcome, what is going to happen, they get more worried. So they worry about heart attacks, strokes, dialysis, hospitalization, and quality of life. And we should be sharing decision making, focusing on preventing this outcome rather just only focusing on your HbA1c and your sugar control. It doesn't mean to ignore the hyperglycemia part, but to make sure that they know what is going to be happening in the future if we don't take it seriously and interfere at the right moment. Um, EMPA provide clinically meaningful reduction in HbA1c and the body weight and systolic blood pressure, as proven from this slide. This make it especially valuable in primary care because this is a multiple benefit from a single therapy that you can use. IMPA in the beginning was first cardiovascular outcome trial to demonstrate the significant reduction in cardiovascular mortality in type 2 diabetes, or established or non-established. This finding fundamentally changed diabetes management worldwide. The reduction in cardiovascular death was observed across different baseline all over, and even with different GFR, with the benefit remained consistent across clinically important subgroup, whether the patient had varying degree of kidney function or previous heart failure. Cardiovascular protection remained evident all over, and regardless of even GFR. The benefits are broad and consistent through the whole spectrum of reduction in GFR. In regard to the safety and the concern that most of us is having, is safety concern are understandable. However, hypoglycemia risk is low, urinary tract infection rate are similar to placebo, and genital infection are generally mild and manageable through patient education. Most safety concern can be managed effectively and easily, so there should not be really concern about the safety of the medication. Um, uh, are we following the guidelines when we're using the CEG2 inhibitors early? Absolutely. Major organization, including the ADA, ESAD, and even the KDIGO, now recommend SGLT2 inhibitor in patients with cardiovascular disease, chronic kidney disease, heart failure, or high cardiovascular risk. Uh, So let's us now consider a patient with chronic kidney disease where therapeutic goal extend beyond glycemic control to preservation of the kidney function and reduction of cardiovascular events. Still, the chronic kidney disease remain underdiagnosed and untreated, despite the significant impact on mortality and morbidity. And this is why early identification create a good opportunity for us to preserve kidney function and reduce the cardiovascular risk in the future. Early detection matters, and we, should consider screening people with looking at GFR and UCR on regular basis. That patient, Salah, is considered high risk patient. Although his GFR appear reassuring, he still have albuminuria. And because of the albuminuria is present, he has a risk for cardiovascular, and it will affect his future outcome. The question is how many CKD cases are missed because albuminuria is not measured? Probably many. Albuminuria often appears years before significant reduction in kidney function become apparent. Both GFR and UCR should be measured routinely, screen with both at all time, and look at them both so we prevent CKD progression. When the damage usually happen long before symptoms appear, by the time GFR falls substantially considerable amount, there will be like before a lot of nephron were been damaged. Waiting for symptoms, that mean we are waiting too long. So the message is to screen for both and look at them and don't miss especially UCR, because sometimes we look at it and see, oh, it's mild, it's okay, the patient is he's fine, and maybe it's a false positive, but it's an indication for serious coming outcome. Most of the patient, fear the word dialysis or hospitalization and loss of independence. So connecting treatment decision to these concerns improve engagement and adherence. You should share decision making, involve the patient, integrating medical consideration and what's going to happen, and how to emphasize this outcome in the future. When to refer patients, usually, many of the patient can be taken care of the primary care physician, and because sometimes, referring patient, it takes time to get him into the right subspecialties, and there is some indication when you are really wants to refer patient is there is recurrent nephrolithiasis, CKD, and hypertension that is refractory to treatment in the range of nephrotic syndrome, and etc. You refer those patients. And the message that is very important, that definitely at the level of all medical health provider, primary care, family physician, they play a critical role in screening, diagnosis, and controlling these comorbidity, controlling and monitoring albuminuria, and initiating of kidney protective therapies. Uh, uh, in the question, does a patient need diabetes to benefit from the IMPA? And the answer will be, no. IMPA kidney demonstrates significant benefit in patient with and without diabetes, and confirming direct and renal cardiovascular protection. Kidney protection extend beyond diabetes. When we look at the slide, and many of the questions that I get on daily basis should be, should therapy be stopped when GFR decrease after initiation? In most cases, no. The initial drop in the GFR reflect favorable hemodynamic changes and should not be confused with the kidney injury. And in real practice, I don't check, GFR after 2-3 weeks. I give it time, because it definitely will go back to where it should be. The evidence only matters if it change what we do in clinic. The practical implementation. how to do it, the easy of using it. What make this it's easy, it's IMPA can be taken at any time of the day. It's easy to store and administer. It's with or without food. So it's simple dosing, minimal titration, broad eligibility, and favorable tolerability make IMPA practical for everyday clinical use. And this slide will demonstrate is according to GFR, because sometimes what patient or physician, we get a little bit worried when we see low GFR. Current evidence support initiation at lower GFR level than many clinical previously appreciated, creating opportunities to intervene earlier. Even, I have a question for our colleague nephrologist. Even now, there's no like big data on even kidney transplant, but it's used in, in kidney transplant, and it's used in GFR above 20, and it is safe. Those few slides is we have many professional society adopted SGLT inhibitor because few therapies have demonstrated such constant cardiovascular, renal, and metabolic benefit across multiple patient population. IMPA is a cardiorenal metabolic protective therapy that lower glucose with simultaneous reduction in, cardiovascular and renal risk. And this is what, the key message in this presentation, that we should think beyond only glucose lowering. And, patient education is essential. Discuss hydration, genital hygiene, sick day management, and recognition of rare adverse event. These controversies improve both safety and confidence. Definitely education will improve the safety. And in conclusion, when your next patient with diabetes, chronic kidney disease, or heart failure walk into our clinic tomorrow, our decision by driven mainly not only with HbA1c, but we have to look long-term cardiovascular and renal protection. Over the last decade, evidence from IMPA, Emperor, IMPA Kidney has transformed our understanding of diabetes management. Our goal is not only now longer just only to control the blood glucose. Our goal is to help patients live longer, avoid hospitalization, preserve kidney function, and maintain quality of life through early cardiovascular protection. The future of the diabetes management is no longer just only glucose. And the question not whether we can lower HbA1c, the question is whether we can prevent heart failure, preserve the kidney function, and help our patient live longer. The home message: treat early, protect the heart, preserve the kidney, improve outcome. I'll stop here and wait for the questions, and we'll be happy to answer.
Thank you very much, Dr. Al-Juhelni, for your excellent presentation and giving us an overview about SGLT2 inhibitors role and highlighting a few educational tips to be considered to our patients. Now we have reached the interactive discussion session. Before we will begin, I would like to remind all attendees that an evaluation survey will be sent to you through your email. The completion of the survey is required to claim your CME certificate and accreditation points. Thanks for everyone who already submitted questions. You have the opportunity now to post your questions in the Q&A sections. So we will start with the first question. We have a lady with a BMI of 46 refusing referral to obesity clinic because of bad experience of her brother with the GLP-1, which caused negative deteriorating mood, refusing also the bariatric surgery. Thinks that diet and exercise are enough to normalize her condition. What is the ideal approach to such cases? The floor is open to any speakers who would like to comment.
Maybe I'll start, Dr. Salah and Haytham. I think we have seen this in our practice, actually, people coming from experience of somebody, negative experience, and expected that the negative experience would be with them. And that's unfortunately not correct, because they don't look into the other people who are very successful in reaching there safely. But my message here, and maybe Prof. Salah, my friend, can also look into that. unfortunately, some people are getting this medication, without even, asking the physician if this is indicated or not indicated first. And they get it from the pharmacy. Unfortunately, it's available in the pharmacies without even a prescription these days. So you cannot really compare somebody who have some bad experience unless you know exactly what happened. How did the patient took it? How was it treated? Was there really a comprehensive planning for this? I mean, in our practice, usually what we do is we do only, gradually and very close monitoring of these people, actually. So I would say diet and exercise probably depends on, again, BMI is very high, 46, would not do alone the benefit. I will leave my friends to comment if they have any other comments.
Thank you, Dr. Ahmed, for the comment, and thank you for the question. I think it's a common scenario, but let me tell you some fundamental things I do in the clinic and I advise everybody to do. I think as a human being, and a patient, they are a human being as well, we jump to conclusion. How we do that, when they come to the clinic, they don't even wait for you to introduce yourself. Well, my name is so-and-so, what you come for? They come here, okay, I want Mounjaro. Oh no, my brother is not good. So they start from the end, and this is where the issues start. And on my advice, I leave the patient talk what they want to do. Then I'll say, okay, let us start from the beginning. I think the key message here is education, education, education. I always say this, when patients come to the clinic and they don't have any previous experience and they are fresh patient, whether they are with diabetes or hypertension or obesity, because you have white paper to write on. As far as they come and they've been treated with something else and they talk to the other patient, they will have lots of myths, unfortunately, and our job is more difficult. Difficult, why? Because we have to clean that and we have to start writing on the fresh. I do, and this is, I found very successful. When you treat obesity, people would like to jump the queues of the assessment, then the plan of the treatment, then the multidisciplinary team they have to see. Because they think, well, I can't take it from the counter, so why go through this? So I think in those patients, you have to go A, B, C. Starts highlighting the problem. And of course, it's not like their problem, it's the environment we are in, unfortunately. But for such patient, I will not leave her for her assumption that she will get. And again, sometimes I tell the patient, okay, so patient, your brother got this and this. Do you know if you don't treat overweight and obesity, what might we will get? And the other message I tell them, sometimes they ask, okay, it's not only about this side effect, there are lots of other side effects they are talking about, cancer, something we didn't know where they hear that from. And I tell them, I'll give you two things. Anything you do to lose weight, it will be less dangerous than you stay overweight with 46 BMI. And the choice is yours. I don't want you to make your decision right now. I would like you to think about it, but come back to my clinic and we'll discuss that further. And please make sure that those patients, you send them to the whole multidisciplinary team. People refuse to go to the dietitian, refuse to go for education to the nurse education, how they take their medicine. Well, my neighbor is taking, that's not right. We have to tick all the boxes. And I think we have very nice checklist when it comes to the assessment for those patients. Somebody 46, I can put all my money that they have most of the complication we talked about and the other risk factor. Thank you.
Okay, another question. We come across patients who try semaglutide or Mounjaro as a pulse therapy and discontinue the medication after significant weight loss after 6 to 9 months. Which patients are the most suitable candidates for GLP-1 pulse therapy? Are there BMI thresholds or comorbidity profiles that favor this approach? And a third question, how do you identify patients at high risk of weight regain after stopping the therapy? It's very long questions, if we can.
Well, let me, again, Salah, if you want to start or I start, it's up to you. Because first of all, let me just say that, I mean, I'm not understanding what they mean by pulse therapy. So do you know what's pulse therapy?
Yeah, and I didn't hear of that. The pulse therapy only on those with big doses of methylbrid or something like that.
That's right.
I think what you mean, those who they are stay on the treatment for some time and then they stop and they want
short
to come
period.
back to the treatment. Yeah.
Yes, yes. Short period, and maybe again, probably when they say that, I assume Salah also they are going in the dose quickly, as I probably you see the same thing. Many people wants to do it quickly. So they keep increasing the dose, not like you and me, we do, is gradually looking into that. Do we need to increase? We don't increase, we keep it the same. So I think that's what they mean by this question. And in that regard, this is really not recommended to do it this way usually. As we said, we like to have it the slower the better, because otherwise you have the yo-yo. We always hear about the yo-yo getting down quickly, they will go up again, and like that after stopping. It's not an easy thing to do it very short and very quick, because really they need during that time to have some again education to continue, to have testing themselves when they start, for example, rewinding the dosing to a lower dose, or sometimes we do expanding the timing. It's a lot of work needs to be done before, say, what they call it pulse quickly and finish. Clearly, these people will fail, and we have examples of these people. Again, unfortunately, as mentioned earlier, because of the cost of not covered. I think somebody will ask a question, I think later on, about the cost is really high and not covered. So what they want to do, actually, that's what they probably call it the pulse. They want to quickly use that money they have to do this and then achieve what they think, and they think that's it. Things will get continue. Unfortunately, that's not correct. So they have to do it, for me, in my opinion, I think my colleague, is to do it very, carefully, under supervision. Actually, my patient, I see them almost every month in the beginning to see what I will need to do after this visit. Do I need to change or not? I have patients, I did not change the dose with a very low dose for a long period, and they're doing very well. So I don't believe of this, what they call it, pulse therapy, or the fast, I would call it fast and quick, dosing. Salah, if you want to.
If you allow me, can I say something about this, because it's a common practice?
Yes, proceed.
Thank you. I think very, very important, guys. We are, when it comes how the medication should be prescribed and how long it is, and it's patient-centric approach, I know, but they are evidence, and we have to stick to those evidence. And there is very clear protocol when it comes to incretins, how to use them. So, for example, when it comes to the titration, it's a titration. So there is one titration used in the randomized control trials. We have to do that. So, for example, Dr. Ahmed, he brings them every month. And what I do, not far from what he's doing, I prescribe the first dose, which is 2.5 and 5 milligram. I'm talking about, for example, now the tirzepatide. And I say, well, if you don't have any issue and you tolerate the medication, you can go directly to 5. If you have any issue, you come back to the clinic. And our nurse educator, if you have that in your place, pick up the phone and give them what we call telephone consultation at the end of the first dose. So this is what I usually do. Patient come and say, well, can I do the text to count the dose? Can I get the highest dose? Can I, because there's nothing in the protocol when it comes to the titration, you count the text. There's special dose, special pen, this is what you should use. Again, when we start, we said, can I tell you something? Apart from the education, you have to continue on this medication for a certain amount of time to benefit from this. Then at the end, there is a high chance, okay, as we have seen from the cross trial, that you might regain weight. Then we have to discuss at that point, and it's usually 6 months' time, whether you want to continue or not. Then it comes the other options, which patient they do themselves. They take it every 2 weeks, they go back to 5 milligram. So all that, we don't have much evidence on whether that will work or not. Patient who they say, well, I want the medication to give me the first push, I want to lose weight, so they do. Then they say, now I want to stop. We say, okay, stop. 3 months down the line, come to the clinic, and see how he's doing. Some of them, they're okay, and few of them, they maintain their weight. The others, they restart the medication. And here start the other discussion. Do I have start from 2.5 again? It's very expensive. Well, if they didn't take it for more than 1 month, yes, they have to start from 2.5 and go through the protocol as it is. The other important point in this, if somebody on other, GLP-1 and they change to another one, so which dose? People, they do it by experience, but we don't have head-to-head trial to tell us which dose we have to transfer. If they are on 5 or 7.5, how much semaglutide they can be on dose-wise. But I advise you, so you don't go into something which you might not know exactly what will happen because you don't have evidence for. Apply what you have as evidence. The costs, it's very important issue, which I think there'll be a question on this in a minute. Thank you.
Thank you. The other comments or question is very long, just I will summarize it. Regarding the refusal or rejection of the anti-obesity medication from insurance company, how to deal with such a frustrating issue, considering that the patients are not willing to purchase this medication due to financial constraints. So how to deal with such situations?
I can start on this because I have lots of let me say argument, and I sit on the council for the medicine in Sharjah and MOH before. I think, yes, struggle. Most of the insurance, they say no. In Sharjah, we have slightly different. We have a committee in the hospital, especially for Sharjah social welfare. Those are Sharjah citizens who are above 45. And if it goes through that committee, we can prescribe the medication for them. But I think there is light at the end of the tunnel because now our colleagues in Abu Dhabi, who they belong to Daman, they prescribe according to certain criteria where patients, they have to stick on medication, they have to do certain number of steps on daily basis, they have to lose some weight before they give. So they give them that free at the beginning, then they continue free if they achieve that target. So I think our colleagues in Dubai, I'll leave Dr. Ahmed to comment on this, they are in continuous discussion with different insurance companies to see how those medication can be insured. But currently, yes, we are struggling. We write too many reports. More than often, we are not successful, apart from the one which covered by the government of Sharjah, where they can get the medication.
Yeah, Salah, for Dubai, I think we have more difficulties. I'm sure about, you said in Sharjah, you have some way to do it. For us, really, even...
Not for insurance, Ahmed, though. It's it's not for insurance.
I know.
Yeah.
Some other way of doing it. But for us, we're talking about insurance, for example, here. Now, as you know, probably in the government, in obesity in general, different than type 2 diabetes, as you know. In type 2 diabetes, even in type 2 diabetes, we have sometimes difficulty to convince, for example, to get semaglutide or tirzepatide. And again, the struggle is there. Most of the people actually for obesity, again, they are not covered. I didn't see anybody covered with obesity management with this medication. But basically what they do, unfortunately, they have to come and purchase it because they are so much educated about the benefit and they like to do it. And some of them, unfortunately, pay from their pocket. I think I agree with you. It's a problem that we need to see the light at the end of this because, again, even, by the way, this is not only here, even Western countries, I know in the US still a problem there. Not everywhere, but they have different way of giving coupon, giving things to reduce the price. But unfortunately, we have difficulty still, I can say about Dubai here. Unfortunately, even type 2, for example, they put for you a level of HbA1c to be high, certain high, if it's not like that. And even sometimes different insurance will say, no, we don't cover this. Why don't you give him oral agents, additional oral? It's really a struggle But I hope we will, and at some time when this going to be solved in a better way than what's happening now. I agree.
A1C 8.5 and above.
What?
A1C 8.5 and
Yeah,
above.
exactly. Yeah. Tirzepatide. The other one is probably a little bit less. Yes, they can accept it. Again, you have to write them letter, say this is having another issues. But as obesity, really, they have struggled. Now, the good news about muscle D, Salah, I think you know that some companies are now accepting to give, the Wegovy, which is the 2.4 for obesity because it's indication, but not everybody. Some companies, with some working with them, with our colleagues from other companies, they try to get it approved for certain people. So we have some success in that.
And the 2 milligram dose as well. Now they
2 milligram is available now. You're right. Yes, that's
Available,
something else for our primary care to know about it, because 2 milligram is available and it's really something good. We've been waiting for it for a long time, but only this year it became available, because I think sometimes with what you're using 1 milligram, you don't reach. I'm talking about diabetes management, come on. You don't reach to the benefit that you like it to be. But 2 milligram have some additional benefit, especially on HbA1c. On the weight, maybe a little bit less than the improvement in HbA1c.
weight is 7.2 coming up.
Yeah.
Okay, thank you. Another question, what is the best phenotype profile for referral to specialist to start advanced treatment of obesity? How long the patient can use GLP-1 agonist without regaining overweight again?
Salah, you want to start?
Yeah. So I think every phenotype you can refer to the specialty as far as they fulfill the definition of obesity and grade of the obesity, because all of them are vulnerable. So all of them, they deserve referral to the specialty. And I always say this about the referral. The doctors who refer, the one who they know. The one who they don't know, they will not refer. The one who they know the danger of overweight and obesity and the complication, and they know that patient might benefit by getting them to the secondary or tertiary care, they will refer patients. I encourage every doctor who they don't have whatever the specialty or the how to manage those patients to refer them. And the second question is, how long the patient should continue to decide, okay, that now the weight regain is less. Weight regain is, our body is quite clever. So the metabolic compensation where, okay, that's fine. To sometime patient losing weight, then our brain compensates, and you see the satiety hormone and the hunger hormone, they interchange, and they are completely different when it comes to the concentration. So people, they start eating again. So it's like our brain is playing around the pharmacotherapy we are giving, which stayed on the time. However, there is another explanation, okay, regarding the set point. So anything to do with the habit, and eating is a habit. So the longer they continue, the better. And when it comes to the habit, from different behavioral study, they say 6 months. Why? Because patients, they start learning the new behavior that they don't eat much, and they have certain food to eat, and the frequency and craving. So those who they continue more than 6 months depend on the behavioral study for the other lifestyle intervention study, the landmark one. Those the one who they have higher chance of them not regaining weight. Those who they stop earlier, or they do, as I hear today, for the first time, pulse therapy or whatever, those the one who they regain weight much quicker. And I think the other point you should add to this, don't stop following the patient up, even if you stop the GLP-1 receptor agonist or the anti-obesity medication, because we do for the other patient, whatever, thyroid, for diabetes. So keep following them up to keep reminding them this is what they should. But if there is any clear protocol how you do it, it's all a personal experience. And I told you the two theory. I tell my patient and I tell myself, which learn from the behavioral lifestyle change, coming from the landmark study of the lifestyle intervention study.
I just might add to what my friend just said is that, again, the all points is very valid. And another point is the basal metabolic rate goes down. When you lose weight, your basal metabolic rate goes down. And that means the amount of food you're eating is going to be a little bit, has to be adjusted. And that's why in the advices we talked about, if this is happening for the maintenance, you need to increase physical activity as well as watching the diet more carefully. And I agree with my friend Salah to continue watching these people to help them succeed. And again, if they start slowly going up, then usually themselves, actually, sometimes they come to us before they go back to the initial weight and start again the medication. And I agree with Salah what mentioned earlier, that if a month, sometimes a month or 3 weeks, a month may be more accurate, we start from the beginning rather than, getting, because they want to come, said, no, 2.5 did not do anything for us, 5 did not do, let's go 7.5. I'm sorry about zipitide here. And that is not the case. They have to start from the beginning, because a lot of experience with people did that. They ended into trouble, and they will probably not be even able to take the medication in the future. I agree with that, sir.
Thank you. I think we have a lot of questions, but we are exceeding the time. I don't know if we will take one more last question. Is tirzepatide safe with a pregnant woman?
No.
No.
That's easy.
Yes.
Okay. But
another quick one is okay.
It's not
another quick one.
Yeah.
Another quick one. The importance of resistance exercise training and adequate protein intake in patients with the GLP-1 therapy and fear of muscle mass reduction.
Very important.
Yeah.
Sarcopenia is an important issue these days. So yes, I agree with Dr. Ahmed.
Looking forward for the future medication that we cannot talk about it today.
Inshallah, we'll
have
talk
some
about it in
beneficial
subsequent webinars.
And the market anyway. So.
I know in the market, but that's not.
Yeah. So we can conclude. Thank you, everyone, for your thoughtful questions and active participation. I would like to extend my sincere appreciation to our distinguished speakers, Professor Salah Abu Sneina, Professor Ahmed Hassoun, Dr. Haytham Al-Jani. Thank you for sharing your expertise, your experience, and your valuable clinical insight with us today. As a reminder, an evaluation survey will be sent through the email to all attendees. It's very important because it is a requirement to be filled to claim CME points and certificate. As we come to the end of today's session, I hope that the discussions have provided you with the practical knowledge and evidence-based strategies that will support your daily clinical practice and ultimately improve the care of patients living with obesity, diabetes, and cardiometabolic disease. On behalf of Emirates Health Service, we thank all for your participation and commitment to continuous professional development. Also, we extend our sincere appreciation again to Boring Intelligence for supporting this educational initiative. Thank you, Dr. Karim Al-Raisi, for the organizing committee and everyone for making today's event success. We look forward to welcoming you again at our future Primary Care 360 educational activities. Thank you very much. Have a wonderful evening.
Thank you all. Thank you.
Thank you all. Thanks.
Thank you.